Hello and welcome to the presentation. In this video we will go through a diabetes medication called Ozempic, or also known as semaglutide. Let's begin. So let's start on what we will cover. So in this video we will go through what is semaglutide, what is GLP-1, what is semaglutide's mechanism of action, its indications for use, how is it supplied, its administration, its dosing. We'll look at some of the common side effects, as well as the contraindications as well, and the precautions, and we'll also look at its effect on weight loss. Now, what is semaglutide? It's a GLP receptor agonist, or a glucagon-like peptide receptor agonist. The thing is, what is GLP? Let's take a look at this. So what is GLP? Glucagon-like peptide. So GLP-1 is an incretin hormone that's secreted from the L cells of our small intestine. And this stimulates the insulin release from the pancreas and inhibits glucagon secretion from the pancreas as well. And this helps to lower our blood glucose levels. And it's released in response to food. Moving on, studies have shown that GLP helps to enhance satiety, or reduce the feeling of hunger, and also helps to lower energy intake. Alright, so back to the question, what is semaglutide? So again, it's a GLP-1 receptor agonist. It basically mimics the hormone GLP. It's also structurally similar to GLP, but there's been some modifications to the semaglutide molecule. And these modifications result in a decreased renal clearance and also protects it from metabolic degradation, so metabolism. And with these modifications, this allows the drug to have a longer half-life. And for this reason, the drug can be given by once weekly injection. Alright, so now that we know that semaglutide selectively binds to the GLP receptor, let's move on and take a look at the mechanism in a little bit more detail. So first and foremost, the drug, it stimulates insulin secretion. And this is important that when we eat food, our blood glucose levels rise. And the insulin that's secreted, this will actually help to bring down our blood glucose levels. Another piece of important information, stimulation of insulin secretion from the beta cells by GLP-1 receptor agonists is glucose dependent. They have activity in the presence of elevated blood glucose levels, for example, after we eat food. And this is where these drugs will potentiate glucose-stimulated insulin secretion. Now, in the absence of elevated blood glucose levels, these medications will have little to no activity on insulin secretion. And this is important because this type of medication helps to control hyperglycemia and also minimize the risk for hypoglycemia. Second mechanism is that it lowers glucagon secretion. Remember, glucagon is a hormone that helps to mobilize glucose. For example, in the liver we have glycogen stores. Glucagon will cause those stores to be converted to glucose. So we're lowering glucagon levels, which will help to lower blood glucose levels. Next mechanism is that it delays gastric emptying. So this allows food to sit a little bit longer in the stomach, so it doesn't move right away to the small intestine where it's absorbed. So by doing this, can also help to lower postprandial blood glucose rise. And finally, it promotes satiety, so a feeling of fullness, so you don't feel as hungry. And also, the way this mechanism works is that there's also some communication between the gut as well as the brain. And we'll come back to this as we progress through the presentation. Let's look at the indications. So with this medication, it's generally used alongside lifestyle changes, so diet and exercise. So it's very important that these are implemented. It can also be used in place of metformin as a monotherapy, and generally that is if metformin is not tolerated or if it's contraindicated. It can also be used in combination with other therapies as well, such as with metformin, sulfonylureas such as glyburide, glycoside, for example. It can be used with insulin, and also with the SGLT2 inhibitors, so canagliflozin, empagliflozin, for example. And finally, this should not be used in combination with other GLP-1 agonists. I highly recommend to go through the monograph to see more details of the indications. There's always research coming out with this medication, so indications can change. So please stay updated with that as well. And also don't forget to check out the Ozempic website. The link will be in the description below, along with the monograph. Alright, so how is Ozempic or semaglutide supplied? Well, these are supplied in pre-filled, multi-dose, disposable pens. So once you use it, you dispose of them, and generally you'll dispose of them at a pharmacy. They come in a 2 milligram pen, and this is for dosings of 0.25 milligram to 0.5 milligram. So generally this is the pen that a patient will start out with. This contains about 1.5 mils of solution, and that's equivalent to 2 milligrams of semaglutide. And 1 mil of the Ozempic solution in the pen contains about 1.34 milligrams of semaglutide. Next, there's also a 4 milligram pen, and this is for dosing the 1 milligram dose. And this is generally the next step after titrating from the 0.25 or 0.5. This will be, the 1 milligram will be the next step in the titration process. And this 4 milligram pen contains about 3 mils of solution, and again, that's equivalent to 4 milligrams of semaglutide. And again, 1 mil of Ozempic solution in the 4 milligram pen contains about 1.34 milligrams of semaglutide. In all the packaging, there are pen needles included, so this can be used alongside the pen. And finally, there's also an 8 milligram pen, and this is for dosing the 2 milligram dose. This one contains about 3 mils of solution, and again, that's equivalent to 8 milligrams of semaglutide. Each 1 mil of Ozempic solution in the pen contains about 2.68 milligrams of semaglutide. We'll discuss the dosings in the coming slide. Alright, so let's move on to storage. So how do we store Ozempic or semaglutide? So it's very important that it's stored in the fridge. An unopened box should be stored in the fridge between 2 to 8 degrees Celsius. Once it's opened, or when the person starts using it, there is an 8-week expiry. Again, when it's opened, it can be stored at room temperature or below 30 degrees Celsius, or it can be put in the fridge and stored between 2 to 8 degrees Celsius. And finally, do not freeze and do not use after the expiry date. Alright, so let's move on to administration. So how do we give semaglutide or Ozempic? Alright, so this is administered by subcutaneous injection, and it's given once weekly. So it's administered subcutaneous, so under the skin, into the fat tissue, and it's given once weekly. And remember, as we highlighted in the beginning of the presentation, that the semaglutide molecule, there has been modifications to it, which allows it to have a longer half-life, and for that reason it's given once weekly. It can be given any time of the day, it can be given with or without food, and generally it's given in the abdomen, stomach region, but can also be given in the thigh as well as the upper arm. Whether you give it in the abdomen, the thigh, or the upper arm, the dose remains the same. So you can change the injection site if needed. The dose will still remain the same. Anytime you inject, it's always important to always rotate the site of injection. And before using the pen, always inspect the color of the solution, so it should appear clear and colorless. Alright, so let's move on to dosing. So generally with this drug, we start slow and we titrate up slowly. This allows the body to get used to the medication and some of the side effects as well. So we start at 0.25 milligram, and that's given once weekly. Generally, this 0.25 milligram dose is not the therapeutic dose. It's just given to help the body get used to the medication and really help to get over some of the side effects, which we will come to in the coming slides. So after 4 weeks, the dose can be increased, and that will be 0.5 milligram once weekly. Again, if additional glycemic control is needed, after 4 weeks, the dose can be increased again to 1 milligram once weekly. And the dose can even go up to 2 milligram weekly. And as we highlighted in the previous slides, there's a pen that can be used for each part of the titration. So the 2 milligram pen is used to dose the 0.25 milligram to 0.5 milligram, and then the 4 milligram pen is used to dose the 1 milligram dose. And again, the final one is the 8 milligram pen, which can be used to dose the 2 milligram. Remember, Ozempic should not be administered by IV intravenous or IM intramuscular. It's only given by subcutaneous injection. Alright, so let's look at the risk of hypoglycemia. Generally, the risk of hypoglycemia with Ozempic or semaglutide is quite low. The risk is increased if it's used alongside other drugs that can cause hypoglycemia. For example, the sulfonylureas or glutamides, these actually cause insulin secretion, and which can lead to hypoglycemia. And other drugs also include insulin, which also can cause hypoglycemia. When semaglutide is added to a sulfonylurea or insulin, the patient or the healthcare professional may need to consider a reduction in the dose of the sulfonylurea or also the insulin. So these should be considered to reduce the risk of any hypoglycemia occurring. Alright, so let's look at some dosing considerations in a little more detail. These are the most common ones, but I highly recommend going through the monograph for more detail. In terms of patients with renal insufficiency, so renal insufficiency didn't impact the pharmacokinetics of the drug. So there's no dose adjustment required for those with renal insufficiency. But it does highlight that with Ozempic or semaglutide, it's not recommended in patients with end-stage renal disease. And the reason behind this is that with GLP receptor agonists, these can be associated with gastrointestinal side effects, so nausea, vomiting, diarrhea. And when these do occur, this can lead to dehydration, which can further deteriorate renal function. So for this reason, it's very important that renal function is monitored in patients with renal insufficiency. In the elderly population, those 65 years and older, no dose adjustments are required based on age. And with pediatrics, those under 18 years old, the safety and efficacy hasn't been studied in this age group. And finally, in patients with hepatic insufficiency, the safety and efficacy hasn't been studied in this group, so it's cautioned to use this medication in this patient population. In this slide, I just want to briefly mention what to do if a patient misses a dose. The first thing is don't panic. The dose can be administered as soon as possible within 5 days after the missed dose. If more than 5 days have passed, the missed dose should just be skipped and the next dose administered on the regular scheduled day. This brings us to another question. What do I do if I injected more than I was supposed to? Well, in the clinical trials, it showed that overdoses of up to 4 milligrams in a single dose and up to 4 milligrams in a week have been reported. The most commonly reported adverse side effect was the nausea. Again, all patients recovered without complications. So the main thing is that it's very important to emphasize that Ozempic is injected weekly and not daily. Alright, so this moves us on to most common side effects. So the most common side effects are usually the nausea, vomiting, diarrhea, abdominal pain, constipation, fatigue. The stomach-related side effects, especially the nausea, tend to be the most bothersome and biggest challenge or hurdle for many patients to get over. And this can also affect compliance. And this is also why we want to titrate up slowly. This will give time for the body to get used to the medication and hopefully get over that hurdle of the nausea. So we start at 0.25 milligram, and then we go to 0.5 milligram, and then we go to 1 milligram. So we're titrating up slowly so the body gets used to the medication. Alright, so this moves us on to the next slide of how do we manage the nausea, because it's one of the most common side effects of the medication. The nausea may occur when starting the medication. It may also occur during dose titration. So here are some tips. So first one is to eat slowly. Eat smaller, more frequent meals. If you're eating too large of a meal, there's more food in the stomach, this might trigger nausea as well. And consider dosing at bedtime. One important thing is that eating foods lower in fat. With high fat meals, this tends to sit in the stomach longer, slows the gut down, and this can also make the nausea worse. Alright, before we proceed to the next slide, I just want to point out that semaglutide or Ozempic is not a substitute for insulin, and it should not be used in patients with type 1 diabetes or for the treatment of diabetic ketoacidosis or DKA. Alright, so let's look at the contraindications of this medication. So it's contraindicated in those with a personal or family history of medullary thyroid carcinoma, also in those with multiple endocrine neoplasia syndrome type 2, or called MEN2. This is just a genetic disorder that affects the endocrine glands. It can also cause tumors of the thyroid gland, for example. Also, Ozempic should not be used if a person has any hypersensitivity to the ingredients or components of this medication. Furthermore, it should not be used during pregnancy or breastfeeding. There hasn't been sufficient studies in this patient population. One of the side effects to be aware of are the rare cases of the gallstones. And this may be due to rapid weight loss with the medication, and this may change or alter the ratio of bile salts to cholesterol in the gallbladder, and this may predispose to formation of stones. Another question arises here that with SGLT2 inhibitors, they also cause similar amounts of weight loss, but gallbladder stones is not an issue with this class of medication. It's only seen with the GLP-1 receptor agonist. So are there other mechanisms involved here that are causing the gallstones? Let's look at this in the next slide. Alright, so let's look at some other possible mechanisms for gallstone formation. So with GLP-1 receptor agonists, they may be having a direct effect, adverse effect on the biliary tree. They may be causing a change in bile salts, which could lead to a supersaturated bile. They may be affecting the gallbladder motility, so this may enhance or increase the amount of biliary content and also increase the chance for bile stone formation. In 2 intervention studies, there was a drug called exenatide and abiglutide. These are both GLP-1 receptor agonists. They had an effect that they reduce cholecystokinin-induced gallbladder emptying, so the contents stayed longer in the gallbladder, which may be a cause for the bile stone formation. Furthermore, another drug called liraglutide, which is also a GLP-1 receptor agonist, it prolonged the time to reach maximum gallbladder emptying. So again, this may be another cause for the bile stone formation. Overall, the exact mechanism of these gallbladder events still requires further study, but it's likely it could be a combination of various factors. If you want to learn more about this, there are some research papers that are in the description below. So since this medication has the risk of gallstones, it's important to know the signs and symptoms if a person does have gallstones. So this includes abdominal pain, bloating, belching after meals, indigestion. It can include fever or even jaundice. Alright, another side effect or complication is pancreatitis. It's rare, but it's important to know. And when the gallstones are formed, this may also block the bile duct. When this happens, this stops or impedes the pancreatic enzymes from traveling to the small intestine, and the secretions get backed up into the pancreas. And this can lead to pancreatitis, so inflammation of the pancreas. And if pancreatitis were to occur, this may include abdominal pain that radiates to the back, nausea, vomiting, fever. The pain may worsen when eating. So in this situation, it's very important that the person sees a doctor right away. Alright, so this moves us on to other warnings and precautions. So that includes risk of thyroid tumors, pancreatitis, also diabetic retinopathy complications. This is especially important if the person already has pre-existing retinopathy. There's still that risk for progression if there's a rapid decrease in the A1C. So it's very important to monitor. Also hypoglycemia. Again, the hypoglycemia is more of a concern when the person is also on another medication that can cause hypoglycemia. So for example, insulin or sulfonylureas or the meglitinides. Also acute kidney injury, hypersensitivity, and acute gallbladder disease. As we highlighted earlier in the presentation, that semaglutide or Ozempic also has an effect on weight loss as well. And so how does this work? We highlighted earlier that it delays gastric emptying, so the food stays longer in the stomach. And this gives a feeling of satiety or a feeling of fullness. Therefore, the person is likely to eat less. Also, with semaglutide, it helps decrease appetite and decrease calorie intake. And the theory behind this is that with GLP-1, it also has its action centrally in the brain, mainly in the hypothalamus. And this part of the brain plays a key role in appetite regulation and calorie intake. So it's like our gut and our brain are communicating with each other. So to sum this up, with increased satiety or feeling of fullness, reduced appetite, and reduced calorie intake, the overall effect will be weight loss. And remember, weight loss is important in diabetes. Weight loss of 5 to 10% of initial body weight can help improve insulin sensitivity, blood glucose control, and as well as blood pressure. Here's another question. What happens when you stop semaglutide or Ozempic? What happens to the blood glucose levels, and what happens to the person's weight? First and foremost, only stop on the doctor's orders. Generally, if it's stopped, the blood glucose levels will be affected and likely will increase. Remember, with semaglutide, this helps in reducing the postprandial blood glucose rise. So after we eat, this drug plays a key role in helping reducing that spike in blood glucose after we eat. In terms of weight gain can return after stopping the medication, especially if lifestyle changes such as diet or exercise is not implemented. And remember, with this class of medication, they also can have the cardiovascular benefits. And by stopping the medication, you're losing the cardiometabolic benefit. Remember, this drug is not a cure, it's just a treatment. So it's crucial to have a healthy diet and exercise regularly to help maintain a healthy weight and reduce the chances of weight regain. So here we have some research or evidence on weight regain after discontinuation of Ozempic or semaglutide. So this is a study called Weight Regain and Cardiometabolic Effects After Withdrawal of Semaglutide, the Step 1 trial extension. This was a randomized control study, so the gold standard. And this explored the changes in body weight and cardiometabolic risk factors after treatment withdrawal. So overall, the results show that 1 year after discontinuing the weekly injections of semaglutide and the lifestyle intervention, participants regained about 2/3 of their prior weight loss and similar changes in the cardiometabolic variables as well. So you can see that if the medication is stopped and lifestyle changes such as diet and exercise are not implemented, there's a high possibility that weight regain will occur. So here we have a summary slide. So overall, this medication helps to lower A1C, it improves blood glucose levels, it helps to lower the fasting and also the postprandial blood glucose rise. It helps in weight loss, cardiovascular benefit. The downside that this is an expensive medication, so affordability can be an issue. Alright, that concludes the presentation. I hope you found this video helpful. Don't forget to subscribe for more videos like this. And again, thanks for watching.